Howdy everybody, welcome back to MSK. My name is Jonathan and today we are going over another terminal branch of the brachial plexus, the radial nerve. Let's hop into it. Alright, to start us off, we're going to go over our brachial plexus roadmap and talk about how we get to the radial nerve from the individual nerve roots. Starting with C5 and C6, they will add together to form the superior trunk, where they will send off a posterior division to the posterior cord and then add to the radial nerve. C7 will shoot straight across and add to the middle trunk, where it will then add to the posterior cord and to the radial nerve. And lastly, C8 and T1 will form the inferior trunk, where they will send off a posterior division to the posterior cord and complete the radial nerve. So as I just mentioned, the radial nerve roots are going to include C5 through T1, which is every nerve root of the brachial plexus. Alright, moving on to the motor innervation of the radial nerve, we will start with the triceps brachii, this muscle here. The triceps brachii are named for their three heads: the lateral head here in yellow, the long head here in red, and the medial head that's hiding behind them in the green. The lateral head and the medial head will originate on the posterior side of the humerus and then insert on the posterior ulna, making them extenders of the elbow. Importantly, the long head of the triceps will originate on the infraglenoid tubercle of the scapula and then go down to insert onto the ulna with the other two heads of the tricep. What this means is that in addition to contributing to elbow extension, the long head also contributes to shoulder extension and adduction, moving the arm behind the torso and toward the torso. The next muscle we'll talk about is the anconeus. If you look down here with these extensors, it is this muscle right about here. As you can see, the anconeus is a very small muscle, and it helps to attach the humerus and ulna similar to the way that the tricep does. And although the anconeus is active during elbow extension, because of its small size, it contributes very little to this movement. Sorry, anconeus. You're just not that helpful. The next muscle we'll talk about will be the brachialis, this muscle here. Because the brachialis originates on the anterior part of the humerus and then inserts onto the anterior ulna, then this will contribute to flexion of the elbow. Importantly, the brachialis is usually dual innervated along with the musculocutaneous nerve. The radial nerve will innervate the lateral aspect of the muscle, with the musculocutaneous nerve innervating the medial aspect of the muscle. The last muscle, or rather group of muscles that we're going to talk about, is the posterior compartment of the forearm, which includes all of the extensors of the wrist and fingers. Because the extensors will have their own video, and there are way too many for me to list them all here, we'll talk a little bit more about the clinical significance of the extensors and what happens if the radial nerve is injured. Because all of the extensors are innervated by the radial nerve, if we have an injury to this nerve, this can lead to something called wrist drop. And you can imagine what this looks like. If your hand is completely unable to extend the wrist out to a normal position, then it might look something like this. Another interesting clinical feature is that you actually need wrist extension for maximum grip strength. And you can test this out on yourself. If you completely flex your wrist over, stick your fingers inside and squeeze as hard as you can, and you'll find it's not very strong. Extend your wrist and all of a sudden, you're back to full strength. What that means is that a question might not tell you that a patient specifically presents with wrist drop. Instead, they might describe that the patient reports having complaints of weakened grip. Maybe they are dropping their items, or maybe they struggle to pick up things. And so you'll remember that because the extensors are necessary for grip strength, that could clue in a radial nerve injury. But a radial injury is not the only nerve injury that can present with weakened grip strength. And so you have to look for other clues to parse out whether you're talking about the radial nerve or the median nerve or the ulnar nerve. And so one of those clues will be any sensory innervation changes in the patient. So let's talk about the sensory innervation of the radial nerve. The radial nerve will cover the dorsal aspect of the arm and forearm in this area here, and it will include the dorsal aspect of the radial hand and, importantly, 3.5 fingers on the radial side. The radial nerve will innervate fingers 1, 2, 3, but will split this fourth finger here with the ulnar nerve. Also important to note is that the very fingertips are innervated by the median nerve, not the radial nerve. And let's talk a little bit about naming conventions. So the posterior side of the hand is called the dorsal side or the dorsum of the hand, and the anterior side of the hand is called the palmar surface or sometimes called the volar surface. and so the radial nerve will be mostly responsible for the dorsum radial part of the hand. And lastly, we'll talk about causes of injury to the radial nerve. The nerve can be injured by a fracture at the mid-shaft of the humerus, or compression of the axilla, maybe excessive use of crutches, or in a funny sleeping position. If you can imagine someone going out and having a little too much to drink on their Saturday night, and they forget to take themselves to a bed, and instead they just sleep in the chair that they're in with their arm hung over the side of the chair. This can put a lot of compression on the armpit, leading to radial nerve injury, as a condition called Saturday night palsy. And lastly, excessive supination and pronation of the wrist. Maybe in a question stem, this will be a carpenter who's using a screwdriver a lot. This can irritate the radial nerve and cause injury. Something important to think about for the radial nerve, especially when it comes to questions, is that it can have very variable presentations because of how long the area of innervation is. The radial nerve innervates muscles in the posterior arm, posterior forearm, and sensation in the dorsum of the hand. What this means is that there's variable presentation based off of the location of the injury. So let's talk about how nerve branches innervate distally, and then we'll go back and talk about what this means for the variable presentations for radial nerve injury. So here we have our humerus and we have our tricep. And running down the arm, I will add our radial nerve. Now coming off of that radial nerve will be the branches that go to innervate our muscle and skin. And so here we'll have our branches that lead to the tricep, and down here maybe these branches will lead to the posterior forearm. And what you'll see is that when this terminal branch comes off the radial nerve, it will travel distally down the arm before reaching its target muscle. So in the case of a midshaft fracture, we may sever the radial nerve at this level. But because the branches for the tricep have already branched off before traveling distally to reach the tricep function may be spared in a midshaft fracture. And instead, the downstream nerves, maybe to the posterior forearm, will be predominantly affected instead. And so here I've drawn the radial nerve coming down and around the arm to innervate the posterior forearm. You can see it's the posterior because the arm is pronated here. And you can see coming off that main nerve are the beginning of branches that will go to innervate the muscles and skin that the radial nerve innervates. And so the branch of the tricep will come off that radial nerve and then travel distally before innervating the muscle fibers of the arm. So even in the event of a midshaft fracture that severs that radial nerve right there, that tricep head that's already come off can still come down and innervate the three heads of the tricep. So let's go over our causes of injury and what their presentations might look like. So as I said, because nerves innervate distally, even in a midshaft fracture of the humerus, tricep function and sensation at the back of the arm may be spared, and a patient will present with injury distal to that. They may have wrist drop, weak grip, loss of sensation on the forearm and dorsum of the hand. Compare that with a patient who has radial nerve damage from compression of the axilla in the case of Saturday night palsy. This patient may have a loss of sensation in the entire posterior arm, forearm, and dorsum of the hand, in addition to weakness with elbow extension and extension of the fingers and wrist. A patient who injures their radial nerve from excessive supination and pronation of the wrist, probably somewhere in the forearm, will probably only present with minor motor deficits, such as an inability to extend the fingers, leading to finger drop. Alright, we just went over a lot, so let's do a recap and then we'll do a practice question together. The nerve roots of the radial nerve will be all the nerve roots of the brachial plexus, C5 through T1. The motor innervation of the radial nerve will include the triceps and anconeus, which will help with elbow extension, in addition to the triceps contributing to shoulder extension and abduction. The brachialis will be shared with the musculocutaneous nerve and will contribute to flexion at the elbow. And the posterior compartment of the forearm, which will house the extensors of the hand and wrist. The sensory innervation of the radial nerve will include the dorsal aspect of the arm and forearm and the dorsum of the hand on the radial 3.5 fingers. And common causes of injury will be a midshaft fracture, compression of the axilla, and excessive pronation and supination all at the wrist. And the site of injury is important for the presentation, with everything below the site of injury being affected in the radial nerve. A practice question might sound something like this. A 55-year-old male presents to your emergency department after a motor vehicle accident. The patient reports decreased sensation in the back of the hand and wrist, in addition to difficulty extending his fingers. Vital signs include a blood pressure of 135/91, a temperature of 38 degrees Celsius, and a heart rate of 99 beats per minute. On physical exam, the patient has reduced sensation on the radial dorsum of the hand and 1 out of 5 strength with wrist extension. Imaging shows a transverse fracture of the patient's humerus. Assuming the nerve damage is from the fracture, what what is the most likely location of the fracture on the patient's humerus? So this patient will present with loss of sensation on the dorsum of the hand, in addition to weak extension of the wrist, which will be indicative of a radial nerve injury. And the most common location of a humerus fracture causing radial nerve injury is at the mid shaft of the humerus. All right, guys, that's everything from me today. Thanks for watching, and I'll see you next time.